Amy, whenever you're ready, you can turn on your microphone and camera and begin.
Hi, everyone. Thanks for joining us for the afternoon breakout sessions. My name is Amy Richardson. I'm one of the presenters later today at the conference, but right now it's my pleasure to moderate this session with Mike Davis. He's a certified orthotist and prosthetic resident at Troop Healthcare in London, Ontario, and works very closely with the amputee program at Parkwood Hospital. I'll hand the mic over to Michael.
Hello. Well, as Amy said, my name is Mike Davis. I'm a resident prosthetist with Troop Healthcare in London, and we work very closely with the Rehab Institute, or excuse me, Parkwood Rehab Institute. So let me just share my screen. All right. Oh. Okay. There we go. Okay, so today we're going to be talking about prosthetic components and specifically indications for torsion units in patients with below knee amputations. Now we decided to do this presentation because based on our conversations at Parkwood with a lot of our own patients and the doctors and the team there, we found out that a lot of patients were asking for torsion units or wanting to trial them based on wanting to golf or wanting to be more active in their daily life events. So I put together this presentation. So here's an overview. What is a torsion unit? We're going to be talking about different examples in the industry, so different types of torsion units from different manufacturers. We'll do a little bit of talk on the research and use of torsion units on lower limb amputees with about 5 or so articles that I go over. Indications for torsion units in clinical practice, which is the main thrust of our conversation here. And then at the end, I really want to open it up to questions and discussion based on what your experiences have been with torsion units with your own patients, or if you know nothing about torsion units, questions on that. So let's get started. So what is a torsion unit? It is a modular prosthetic component that allows for a limited range of elastic motion in the transverse plane. It can come in varying stiffnesses depending on patient's weight and activity level. So basically it's used for rotation when the foot is planted. So it has shear motion between the stump and the socket are reduced as a result of the motion, of the torsion unit. So this is not to be confused with a rotator unit, which looks very similar, but it allows an above knee prosthesis to fully rotate at the pylon and foot 360 degrees by clicking a button. So that allows for the patient to flip their leg up and put their shoe on and whatnot. But we're talking about the actual torsion unit, which absorbs torsion. And then this can be used with both above and below knee prostheses, but we're going to be focusing on below knee prostheses today. So some examples in the industry. So the Autobach version of the torsion adapter with multiple connections, it's modular. It's used for maneuvering in tight spaces or for recreational purposes. And here's a picture of it here. So this is one of the more common torsion units. It's very simple. It just does the torsion motion in the transverse plane, as opposed to their delta twist, which is a shock absorber and torsion unit combined. So this reduces shear forces, and it's used at work for leisure activities which cause frequent there. I'd say that we tend to use this a little bit more because it has both the shock absorption and torsion combined as a normal torsion adapter. And we'll talk about the pros and cons of shock absorption with torsion combined when we get to the research. So the next example, torsion shock absorber. So it is for lower limb prostheses. It's used for low to high impact and all walking speeds. And of course, shock absorption and rotational functions that reduce rotary and shear forces on the residual limb. So this is a picture of Oser's torsion shock absorber. We use this one as well, and we've put it on a couple of patients recently, and they really like it. It's also really nice, this one in particular, because it is a piece that can just be added in right at the end, and it's as opposed to the Autobach, which is a larger component in the vertical aspect. This one you can squeeze into tighter spots. All right, next we have the fill-hour torsion adapters. So there's 3 different types of stiffness options with this one. They're made out of durable titanium core, and they're relatively maintenance-free. And of course, it reduces rotational forces to the residual limb. And then it's got a rotational stop at plus or minus 45 degrees. So the patient can't go in a full 360-degree motion there. So these are the pictures of their type of torsion adapter. So each one is a different stiffness. And so you just choose that based on the patient's activity level. All right, next we have the Blatchford, formerly Endolite. So theirs is called the TT Pro, Transtibial Pro, or Torsion Pro, excuse me. Cushion shock and shear forces caused by vertical and twisting motion. It protects the skin interface from abrasion and discomfort. And here's a picture of this one. So truth be told, I don't have really any experience with this type of torsion adapter, but I assume it works very similar to the other ones we discussed. All right, so getting into the research, there's limited research on the topic of torsion units in general within the field of prosthetics, just because there's limited research in prosthetics in general. Torsion only has about 4 or 5 articles that really dive deep into the research of the functional effects of torsion units on lower limb amputees. So the articles that I looked at were Shu et al., Gard et al., Heitzman et al., and Kloot et al. So all the studies included only a small number of participants, ranging from 2 participants to 12, which is very small in the grand scheme of things. So the main focus of the studies were on transtibial patients experiencing shear forces while ambulating. And then 2 of the articles also examined shock absorption units and multi-axial feet. So they focus on that because that's mainly the experience that patients are wanting to know about, or prosthetists want to know about when it comes to torsion units, is when walking, how much shear force can we reduce by using these? So in the end, I found that 3 out of 4 articles found that torsion units significantly reduced shear forces on the patient's stump during rotation in the transverse plane, which led to an increased comfort for the patients while they were ambulating. So that's, even though there's only a small number of articles, that's a really good findings showing that the shear forces are quite reduced when using a torsion unit. So that leads me to the overall indications of the torsion unit in below-knee amputees. So an indication would be unnatural asymmetrical gait patterns in terms of rotation in the transverse plane, overloading of the residual limb and locomotor system due to the impact load and shear forces, significant sensibility against impact loads such as formation of edema on the residual limb, pronounced dynamic gait patterns, and frequent torsion stress at work and during leisure activities. So personally, that last one is the main reason why we put a torsion unit on our patients. It tends to be higher activity level patients that want to, golf is always a big one, or patients that have young kids who need to turn quickly when the kids are running away from them. Seems to be another reason why people like to have these. So based on the articles reviewed, majority of patients with lower limb amputations would benefit from the use of torsion units. Basically, what I came to find after reading these articles was that most people are candidates for a torsion unit and would benefit from it with the shear forces being reduced as much as they are, especially ones that have shock and torsion units combined. But there is a cost that is associated with having a torsion unit added. It tends to be not exactly cheap in the eyes of most patients. So this is where I want to really open it up to questions and discussions. I know that was brief compared to other presentations, but this is really meant to be kind of a discussion on what other people found in their daily clinical visits with their patients, and kind of ideas on what you all think should be used with our patient population. Thank you for your time. And these are my references.
Thanks, Mike. I'll give everybody a moment to type their questions in the Q&A section. While you do that, I have a question that I can ask to get things started. With limited research and often sort of funding challenges, what's some of the advice you give to your patients or things you suggest they consider when trying to decide whether or not to incorporate a shock or a torsion component into their prescription?
That's a good question. So when it comes to people asking about it, we really start to get into the details of what exactly that they're doing on a daily basis. We just had a patient come in, and he's in his 30s, and he is getting everything from top to bottom, basically elevated vacuum, really nice stuff. And he wanted to know if he could reduce the shear forces so that he could go about doing stuff with his children, going hiking, all that kinds of stuff. So in this case, he was a WSIB patient, so the answer is obvious. We'll give him whatever he wants. But if that wasn't the case, we would say, if you're really not hurting for finances, then this would improve your quality of life, especially if you have a lot of activities to do with your children. Now, say a patient comes in who has diabetes, and that's why they lost their leg, and they're a little bit older, and all they do is sit at home or they golf. Maybe that's not something for them. But if they're golfing every day and that's something that is causing them issues on the golf course, then yeah, sure, we'd bring it up and tell them what our thoughts were and which ones that we would go with. And we would also show them the cost of the different types. So really, it's a conversation that you have to have with your patient to get an idea of their funds and what kind of activities that they'd like to do.
Thanks. We have a question from Chris Garner, who says that he's a LBK, so left below knee amputee, and currently using the fill-hour torsion adapter, who just received it last week. He also uses a quick change adapter, and it doesn't work with the torsion unit, and he's wondering if there's a unit that does work with the quick change.
That is a good question. Yeah, I feel like it should work with that. I'm assuming that he's had this conversation with his prosthetist. I'm not sure why it wouldn't work. I guess I would need more context to fully understand kind of a situation. Sorry if that wasn't, I know that wasn't exactly helpful or what he was looking for. Do you know anything? No. Yeah, should work.
Okay. Maybe you can provide some more information or connect with this prosthetist as well. Feel free to add more questions into the chat there. Mike, with your sort of close work with Parkwood, is there any sort of interest or thoughts on the horizon of contributing to sort of that body of evidence? If this is sort of components you're using often, like doing a quality of life study might be interesting just off the top of my head.
Yeah, of course, that would always be a good idea, is to get more research out there. And we definitely have the patient population to do it. And that's something that I guess I would need to talk to Dr. Payne about, because was the one that came forward with this idea in the first place. But I'm sure he'd be open to it. We would have to get a team together to do the research part of it. And then, of course, finding the correct patients and deciding which of the torsion adapters we would use. But yeah, I think that would be a great idea.
We have another question from Rebecca Kelly, who's a prosthetist in Toronto. She's asking, what is the patient feedback like? Does anyone report those reduced shear forces, or do they just find it more comfortable when they walk, etc.?
Yeah, that's another good question. I would say 99% of the patients that we put a torsion unit on really love it. They find that it helps them. Now, most patients don't use the words shear force, but they definitely say like it's much more comfortable to corner around a building or something, or if I'm golfing, I definitely feel less of that knee twist, as well as a little bit of cushion when they are walking. So yeah, they definitely find it. I have not putting one on, someone being like, "Ooh, this is not for me. I don't like this at all." But I'm sure there are cases out there like that.
Great, we have a few more questions coming in. The next one says, thanks, Mike. Do torsion units need a lot of room? I have a knee disarticulation and not much room left with an X3. So maybe the lowest build height option you could suggest.
Yeah, so depending on the torsion unit, they all have different build heights. So the fill hour one is fairly small build height. With a knee disarticulation, there's not a lot of room in the first place, so it would extend their knee center out if that if we had to put one on him. The X3 though has a little bit of torsion in it. Yeah, I would say the X3 has torsion built into it already, so I would think that's they would be comfortable with that. But yeah, I mean, if you're willing to sacrifice a little bit of length as far as your knee when you're sitting down, your leg will be a bit longer. Yeah, it would work.
Okay, another question here from San Paulos. Do torsion adapters have any impact on gait quality, and do outcomes improve when physical therapy is provided when the torsion adapter is installed?
Yeah, so yes, most patients find that their gait quality improves with torsion adapters. It just feels that much more comfortable and that much more natural. The human body naturally has a little bit of twisting in the joints and all of that stuff. So adding a torsion adapter kind of simulates that. Patients get more comfortable walking and twisting and whatnot. And does it improve with physical therapy? I don't see why not. I'm not a physiotherapist, and I'm sure some physios at Park would be able to speak better on that. But I don't see why that would be a negative. I think the more stuff you have when you're learning, and when you're with a physio, the better.
I can speak to, I've had clients report they get torsion adapters for certain activities like golf. And some of the biggest impacts they find on their activities of daily living. One client reported the best case scenario was when he was cooking in the kitchen, he could turn and pick up stuff, and when he was working in small spaces without that socket rotating on the limb. And his golf game unfortunately didn't improve, but it was more comfortable. So we have another question here from Kylie. Oh, sorry, Mike.
Oh, no, I was just going to say golf, I keep using that as an example, kind of like you just did. That just is the most common reason why people want torsion adapters, it seems. But yeah, sorry, go on. That was just a side note.
That's okay. This might be our last question. I know we're getting close to our 2:30 stop. Kylie is asking, has there been any patient feedback in terms of the added weight of a torsion adapter?
Not that I'm aware of. None of our patients have ever said that. I mean, in the grand scheme of the weight, a torsion unit is not that much more added weight that someone would know. Yeah, good suction or good pin suspension. Yeah, thank you.
Great. And I think we'll just end it with just some great feedback from Chris here, who's saying that it actually really helped his golf. There you go. There is great feedback from someone who's using it that it is worthwhile for that sport. So thanks so much, Chris, and thank you everybody for attending this breakout session and the great questions. And thanks, Mike, for the presentation.
Yeah, of course. Thanks for having me.
Okay. And I think we have a 5-minute break right now, and then we'll have our rescheduled keynote at 2:35. Thank you, everyone.